Thank you very much, and thank you for inviting me, as usual, to this annual meeting. I know it's a different scenario because this is virtual that we're doing, and I know before we talk about the relapsed myeloma, I would like to acknowledge Dr. Ganguly. He gave a great and outstanding lecture today, Myeloma 101. And he is actually one of my mentors, who actually brought me from University of Arkansas. So I really always enjoy not only working with him, also learning from him. So I always learn a lot of great stuff from his lecture. So he's one of my best mentors I ever actually worked with in the past few years. So as much as it kind of like that great connection, he's also leaving our university to go to Houston. So it's going to be a big loss for KU Medical Center, but he's one of the best mentors I would like to appreciate and acknowledge. Today we're going to talk about relapsed myeloma and also the clinical trials, and I will actually going to try to answer some of the questions that was actually brought up. But, as we talked about that, we get the diagnosis of myeloma, we treat the myeloma, we put the patients on remission. The major question is that what's the thing that happened after that? Patients will relapse. The majority of the patient will relapse. And otherwise, we would actually say that these patients have different types of relapse. And the big question patients ask us, how does the relapse present? And we always tell the patients it depends on how they come by. So some of the patients will relapse like what we call the typical myeloma presentations with new bone lesions, possible renal failure, possible patients having anemia. Some of the patients, we will find it by actually the surveillance that we do. We check their myeloma markers, the free light chain, the serum M protein, very closely in order for us to kind of identify if these patients are relapsing. And if I start seeing these myeloma markers increasing by chance, I will consider these patients are relapsed. I will consider maybe doing bone marrow biopsies, imaging studies, just to make sure I'm not I'm evaluating the burden of the disease. But I will not wait till they actually develop any kind of end organ damage. Sometimes these patients, unfortunately, incidental findings. We do an imaging studies like a yearly or something like that, and we find a new soft tissue, a plasmacytoma, and this plasmacytoma is confirmed with a biopsy, even with the myeloma markers being low. So this is actually another form of relapsed myeloma that we see it in patients. And a rare form of myeloma, relapsed myeloma, is a plasma cell leukemia, when you start seeing like some plasma cells, these abnormal plasma cells in the bloodstream, and that's one of the worst types of relapse of multiple myeloma. Anyhow, when you have that, you need to actually start thinking about the strategy of putting the patient back in remission. Yes, we try to think about that to get the patient back to remission. However, we have a lot of options of therapy, but it's not an easy way to go ahead and choose any option of therapy and just pick up this regimen and put the patient on this treatment. There's a lot of factors that really play a big role in treatment of multiple myeloma or deciding what triplet therapy or what medication we use for relapsed myeloma. So one of them is we look at the patient, any kind of the patient-related conditions like the fitness, comorbidities. We evaluate that. If the patient have any possibility of decompensated heart failure or acute coronary syndrome, liver failure, how's their performance status, what's their social situations, and also their preference. Some patients have preference that they travel a lot and they would like less visits to the infusion center. So we try to pick up these things and try to adapt it. Therapy related is also sometimes play a big role. What kind of treatment the patient received in the past? How is the response for these patients? What kind of side effects they develop? So sometimes patients had Revlimid and they barely tolerated for 3 months because they have major side effects like fever, chills, or rash, or maybe anaphylactic reaction. So it doesn't make any sense to try any of the Revlimid or any immune modulatory drugs in the future. And disease related, what type of relapse the patient have, and sometimes we look at the cytogenetics and the disease burden that we'd like to kind of like evaluate. So there's a lot of factors that a myeloma doctor or an oncologist have to actually look at in order to make a decision what type of therapy they're going to use for this relapsed refractory myeloma. Now, saying so, in multiple myeloma and relapsed myeloma, there's many classes of treatment that we have, and every class really represent a very great option for the myeloma patients. So you have immunomodulatory drugs, the thalidomide, which is an old drug. We don't use it very often anymore. The Revlimid and the pomalidomide, we use it very often. The proteasome inhibitor, that is Velcade or pertuzumab, carfilzomib, and ixazomib, or the other name is Ninlara, which is the oral form of the pertuzumab. Steroids, of course, you have to add that for all these patients. Hydac, which is panopinostat, it's rarely that we use for this for our patients. But the newer treatments that now we're seeing is the monoclonal antibodies like Darzalex or Daratumumab, Elotuzumab, and recently the approval of Isotoxymap. And there's newer agents like Selinexor, Belantamab, Melfiqin have been approved for later relapse for these patients. Now, to talk about that in myeloma, we have many options for these therapies. We don't actually treat a relapse myeloma, especially first relapse, with one single agent. We actually treat it with either doublet agent, 2 drugs, or 3 drugs, which is the majority of the times. So you have to kind of have different classes and combine it, 2 different classes with steroids in order to make the right triplet therapy. So we have a lot of evidence that these type of triplet therapy really work very good. Unfortunately, the problem here is that with every single time we have a patient who relapses, we have a major issue with that. It's very difficult to get them in remission, and it's also, we have like what we call a short time of keeping them in remission. And every time they relapse, kind of new mutations develop, more resistance to the treatment actually start to evolve. And that is the main challenge that we face as myeloma doctors. So we always have to try to pick up newer treatments, newer classification of classes of drugs that can be very effective in treatment of relapsed myeloma. But if I actually kind of get it right, we have a lot of options of therapy, but we have a problem, what we call the traffic. All these triplet therapy that we use, a lot of patients when they come and say, well, the first relapse, what would I use? I have a lot of options. It's very difficult to choose which one is better. Now, some patients will think that's a good thing. Some myeloma doctors have to say, well, it's a good thing, but also we don't know which one is the best as efficacy. And that's a very important thing for me as a myeloma doctor. As you saw from the previous slide, is that the majority of the patient, every time they relapse, the remission time will shorten. So I want to try to choose the right regimen that can keep the patient in remission longer as possible. But the problem is that we don't have any effective randomized clinical trials that compare these 3 drugs versus 3 drugs. We do have a lot of options, but we don't know which one is the best. So the myeloma doctor have to kind of like look at the patient, look at the preference, look at the type of disease and the previous treatment that the patient have in order to choose the best option that the doctor believe it is the right option for these patients. Talking about all these options, I want to kind of like really focus on several drugs that really are the main core of these treatment for relapsed myeloma. Daratumumab, that Dr. Ganguly has said, it emerged really fast from really late relapsed myeloma. It used to be option for as a monotherapy, and those who relapsed multiple times on several treatment was really effective. It's an antibody that targets CD38, have multiple mechanisms of actions to kill the cancer cells, including immunotherapy treatments, forcing your immune system to attack myeloma cells. Really tolerated treatment. Patients, have one issue in the past with it was the IV form, and I don't know how many patients still on IV. The first dose, I used to tell patients you have to stay in the clinic for 10 hours, and I mean, imagine like telling a patient about that because of the infusion-related reaction, and the rate was very slow in the first dose, and then after that 4 hours, subsequently the dosage or the duration of the dose dropped down. But now it's much better because the FDA approved a subcutaneous, an injection form of the Darzalex. So instead of like waiting 10 hours, the first dose usually we give the injection and keep the patient for observation between 4 to 6 hours. So we can avoid any possibility of reaction. And if they tolerate that well, then the subsequent doses just take the reaction and they can go home, So this is kind of like becoming one of the best options of therapy in triplet therapies. Isotoxymap is also a newer treatment that we have actually approved by the FDA. It's really not that much different in terms of like, it targets the same thing that Darzalex target. And I have a lot of oncologists ask me if the patient progresses on Daratumumab, is Isotoxymab a better substitution for that? And I answer very, very straightforward. There's no studies to prove that. You can try, but there's no studies to prove it. You can't tell the patient like, it works up to 30 or 40% because there's really no studies. So we are trying to see if there's any kind of studies that prove that doing the Isotoxymap after patient failed the daratumumab, can it work or not? We need more studies to show if it's really effective or not. Elotuzumab is another agent that we see in relapsed myeloma, and elotuzumab is another monoclonal antibody. What it does is actually really amazing. It goes to a receptor on the natural killer cell, which is one of your immune cells, and also that go and attach to the receptor called SLAMF7, and that receptor itself also is present in the myeloma cells, and it tries to kind of like put them very close to each other to force the natural killer cell to kill the myeloma cells. As a single agent, it's really not effective. But if you combine it with immunomodulatory drugs like Revlimid or pomalidomide, it's really effective treatment. And it proved that by the randomized clinical trials. Now, talking about that, we do have a lot of options of therapy. And as I say, all these options of therapy is really great that we can actually offer it to the patients. But sometimes we have to make the right decision by looking at the patient himself, the condition of the patient, the comorbidities, and also the patient preference, and what treatment the patient was on and he relapsed. So for example, let's say the patient was on maintenance therapy of Velcade and he progressed on that. What options you will choose? You can see there's multiple options, multiple trials that showed that, for example, Revlimid-Dex, Carfilzomib Revlimid-Dex, Elotuzumab Revlimid-Dex, and one of the options I kind of offer to patients who intend to kind of like travel a lot, and they don't like to come to the infusion center, Ixazomib Revlimid-Dex. That's all oral therapies. So all these options are really valid to give for these patients. And now, common question patients ask me, which one you think it's the best? They never actually compare each one of them together. So I never actually answer that question. I have my own preference, but it doesn't mean my preference that it shows that preference it's more effective than the other drugs. But what if most of our patients are on maintenance therapy like Revlimid or IMiD-based therapy, and usually when they progress, it doesn't make any sense to put them on the same Revlimid-based therapy regimen. So we try to change it, and there's other options for that. As we talk about Darzalex and Isotoxymab, you can combine it with Darzalex Velcade-Dex, or Darzalex or daratumumab Carfilzomib-Dex, and Isotoxymab Carfilzomib-Dex as well. Some other options, which I don't know, we don't use it very often, but Carfilzomib Cytoxin-Dex, and sometimes, which I rarely use it, Carfilzomib-Dex as a doublet therapy. If the patient have a lot of comorbidities, I might consider using that. So we have a lot of options even for those who progress after Revlimid. Pomalidomide-based therapy also is a good option, and it can be combined with Velcade, Isotoxymab, Elotuzumab, and daratumumab. And all of these options, I kind of like save it and use it in those who are refractory to Revlimid, more likely. And you can see that we have all these options. But what we do here in KU is different. It's kind of like straightforward. If the patient progresses after the first line of therapy, we tend to kind of use daratumumab-based therapy. Any of the daratumumab-based therapy, whether Revlimid-Dex or Darapom-Dex, Carfilzomib-Dex, and also Velcade-Dex as well. And the Isotoxymab also is a fair one that we actually like to use. And there is a reason for that. The Darzalex and Isotoxymab, first of all, it's a well-tolerated treatment for all the patients. It can be combined with all other classes easily. It has been proven all the 6 randomized clinical trials that adding the daratumumab add more benefit in these patients, and well-tolerated for these patients. So here in KU, we kind of like our first line after a patient relapse, the first line is considering Darzalex. In the past, it used to be very difficult with the IV daratumumab, talking to a patient that he should come and stay the first day over 10 hours. Now with the sub-Q, it's much better, much easier to convince these patients to receive the Darzalex-based therapy. So most of our patients, if not all, are receiving Darzalex-based therapy as a first treatment. But what happened after that? Every single line of therapy, we move on. We have a lot of options. And every time you relapse, your chances for your myeloma to stay in remission longer becomes lower. We have a definition of triple class and pentaclass refractory. And for those to know what is triple class refractory, is that you have 3 different classes of myeloma, the 3 major ones. The monoclonal CD38, which is either Dara or Isotoxymab, the immunomodulatory drugs, which is Revlimid and pomalidomide, the commonest, and the proteasome inhibitors, which is Velcade and carfilzomib, that we kind of use, or Laro. If you're refractory to the three of the three classes, then you have what we call triple class refractory. If you're refractory to 5 of the drugs, which include both immune modulatory drugs, Revlimid and POM, and both proteasome inhibitors, carfilzomib and Velcade, and one of the CD38, which is either Dara or Isotoxymab, that's penta-refractory. Why is that important? Unfortunately, the importance of that is the survival. Those who are triple refractory, the survival after these is 9 months, the median survival. Those who are penta-refractory, the median survival of 5.6 months, meaning like we need to find a better treatment options, instead of reutilizing the other drugs, trying other options, alkylating agents. So the FDA actually approved multiple treatments. And I want to actually skip this one, actually, the selinexor. I want to talk about that because that was one of the drugs that got approved by the FDA. And it was the exportin, which it's actually an exportin or XPO1 inhibitor. And what it does, that the XPO1, it really actually, it works as an exporter to transfer the tumor suppressor proteins from the nucleus and the glucocorticoid receptors from the nucleus to the cytoplasm. So the selinexor inhibit that and kind of like causes retention of these tumor suppressors proteins and the glucocorticoid receptors inside the nucleus itself. Now, clinically, is it effective or not? So it was actually studied in the STORM study. And the STORM study actually kind of evaluated that, finding that the response rate in those who are triple and penta-refractory was ranged between 25%. Progression-free survival was around 3.7 months, but it has side effects about thrombocytopenia, nausea, vomiting, that patients need to be on anti-nausea medications, anorexia, weight loss. However, it has to be given with steroids as a single agent. The response rate actually in the initial studies was 4%. So the drug is really effective when you give it with steroids. Some other studies that got approved was the Boston trial with selinexor Velcade dex to treat it after first or second line of therapy is not really actually something that we really like to consider because we have a lot of options, the daratumumab-based therapy and Isotoxymap in addition to Elotuzumab. So it's very difficult to put the selinexor Velcade dex with these other options of therapy. Another drug that FDA approved also is for relapsed refractory myeloma after triple refractory myeloma after patients who are heavily treated is belantamab. And belantamab, for those who have to know, I want you to remember the word BCMA, B-cell maturation antigen. That's the target on the myeloma cells. That's where the belantamab and the CAR T-cell that we're going to talk about and the BiTEs really work very good and effectively against these. The belantamab here, actually, I want to just say that it actually is an antibody that actually attached to chemotherapy, very toxic chemotherapy. We call the MMAF or monomethyl auristatin F. Like imagine that's a very toxic chemotherapy. Once that antibody attached to the myeloma cells, it tried to enhance the immune system to attack the myeloma cells, but also inserts that MMAF inside the cancer cell and causes destruction of that. The initial results as a single agent show that it was showed a response of 67%. But when they tried it on triple refractory and penta-refractory treatments, the response rate was about 35%, with a progression-free survival around 3 months. Now, the good thing about it, it's an IV drug that it's given every 3 weeks, but it has side effects, eye toxicity, and we call it eye toxicity because for some reason it causes some issues in the cornea. So these patients have to be seen by an eye doctor every 3 weeks prior to every treatment. There's no surgical intervention needed, and the only way if the patients start to have any signs of this eye toxicity by the ophthalmologist is to stop the treatment and evaluate it, and in order for it to be reversed. Another treatment that got approved recently is Melfiqin. And Melfiqin, for a lot of people, just to understand, it's kind of like one of the highly alkylating peptide that is significantly, was made in order for it to focus on the cancer cells, enter the myeloma cells, and there's a specific type of enzyme that will try to dissect it in order to kind of force that chemotherapy to go and kill the myeloma cells. So it tries to kind of focus all the cancers, the chemotherapy, to go ahead and kill the myeloma cells. Now, as effectiveness, in order for it to kind of kill as much as possible myeloma cells and have less toxicity in your all normal cells. The FDA approved it based on the Horizon trial. The response rate was 29%, being progression-free survival was about 4.2 months. Overall survival was 11 months. And those patients were triple refractory. So the only issue about it is it's the cytopenia, which is white cells below, platelets will be low, and anemia, and patients have some anemia. However, that was also the third drug that got approved. Now, we do have great options here now, and the FDA just recently approved the CAR T-cell. And for a lot of people to understand what is CAR T-cell have been evolved in the past, in order to treat lymphoma and acute lymphocytic leukemia. And we were thinking about, can this be a great option of therapy for myeloma? And I think there was some results about CAR T-cell to focus on CD19. And I just want to go and talk a little bit about what is CAR T, is chimeric antigen receptor T cells. And what is that actually? So what the scientists do is that they use your own T cells and they kind of manufacture it. They put like what we call laser tag. And this laser tag will attack the myeloma cells. In normal life, what these T cells have to do in your attack infection and attack the cancer cells. But some of the cancer cells are very clever enough that they can actually hide from the T cells. So what the scientists kind of like did is that they took these T cells, manufactured it, and added these laser tag. And they choose like some target therapy. Now, the target therapy they liked in myeloma was the BCMA, B-cell maturation antigen, the same thing that belantamab chose. And the results of that was really amazing. So after they take these cells from the patient and manufacture it, they try to amplify it, make more of these T cells. And then they go ahead to the patient, and after it takes them 4 to 6 weeks to kind of like do all this process. They give this small dose of chemotherapy, what we call lymphodepletion, and the two chemotherapies we use is one called fludarabine and the other one called Cytoxan. And after that, we infuse these T cells back to the patient. And it goes and finds the myeloma cells and attach to it, and through some mechanism of actions, by producing cytokines, it go ahead and it destroys the cancer cells. That's what normally happens. So the question here is that as great as this mechanism of action, is it safe, A? Is it effective, B? And how effective it is? That's a very, very important question. Number one, is it safe? It has some side effects, but are these side effects worth it and manageable? So we're going to focus on the KARMA study because that was the study that the FDA approved, the treatment, which we call ide-cel. They have side effects for your counts. It can drop your neutrophil counts and platelet counts. However, if patients have these counts dropping, it can be also recovered. But one of the more important side effects that we actually notice about these patients is something called cytokine release syndrome. These T cells tend to, when they attack the myeloma cells, tend to produce these cytokines, which is interleukin-6, tumor necrosis factor, interferon gamma, and these tend to actually be maybe overexpressed, and causes some side effects. These side effects could be very mild, some fever, some chills, that you can give a small dose of Tylenol and patient is doing better. It can be very severe to the point that patient's blood pressure drop down and you need to admit the patient to the ICU, and it can cause some shortness of breath that patient need to be on a ventilator. So we have a grade for this system. Thankfully, the grading here for this, showing that the grade 3 was about 5 to 6% only of the patient, which means like their breathing is worse and may need ICU. So the majority of the patients who get the treatment, most of them, when they get the cytokine release syndrome, they can be treated very easily. So the reason why we admit the patients for this is to monitor for the cytokine release syndrome. Another side effects we kind of look at is the ICANS, which is the neurotoxicity caused from the CAR-Ts. And although, these neurotoxicity could be ranged between simple headache, confusion, lethargy, it could be worse to seizures and cerebral edema. And that's where, more intervention needed, like steroids and all these stuff. So the grade 3 good thing about it, it's really actually low. It's about 3% of these patients who can get that. Of course, we can see infection for these patients because you're dropping their counts down. And we also always notify patients that, with the cytokine release syndrome, in case they have it, we have some drugs that can reverse it, like tocilizumab, steroids, and some also other medications. Now, as safety, in my opinion, with those patients who are triple and penta refractory, I think that's really a great option, it's really safe, manageable as well. As efficacy, again, for those patients, so let's focus on the KARMA study, you can say that the response rate for these patients is around 73%. Now, for me, I'd never compare oranges to apples. And the reason for that, because, a lot of myeloma doctors will do it, say, let's compare this one to the STORM study where you have selinexor 25%, this 73%. It's not fair to do that. But as a myeloma doctor, when I see that response rate in patients who exhausted all their options, 73% is really impressive. Not only that, 33% of these patients went to complete remission. That is really great after you relapse after multiple lines of therapy. Now, a lot of patients, unfortunately, that use the word, is this curable or not? It's not curable. That's the disappointment, because patients will relapse after that. And the relapse range, and it depends on, what response you got. So those patients who, in general, all the patients who got the the treatment, and regardless of what response, 9 months was their progression-free survival. But those patients who got complete remission, it went up to 19 months. So it depends on your response. If you go deeper response, you can stay in remission longer. Now, I know it's a little bit disappointment that these patients still relapse, but if you look at it from a different end, this is very good and a great start. And there's a lot of options that they're trying to hopefully improve the efficacy of this CAR T-cell to make it more effective and last longer. If you look at other positivity, this is a one-time treatment. So if I want to look at the worst scenario, a patient staying in remission for 10 months after one treatment and being in the hospital for 7 days, is it worth it? Yes, it is worth it. Considering that the other options, like you have to be on the treatment, you have to stay on the treatment, you have to come more often, the side effects, if you stop the treatment, there's a likelihood that the disease will come back. Here, you're talking about one-time treatment. This is a great break for the patient. This is a great quality of treatment, I say, for these patients. They can, do whatever they want to do, visit. During the pandemic, we have a lot of issues, for these patients. Like, we have to stop most of the treatment because we were a little bit worried about that. So imagine yourself getting the CAR T-cell. You don't have to be worried about getting your treatment. You don't have to be worried about stopping any kind of treatment to go to any procedures, any surgeries. These are things that we look at it as a positivities. Now, a lot of people ask me about, what about the manufacturing? Is that something you're concerned? Of course, I'm concerned about it. 4 to 6 weeks, it's really too much. And we're not happy about that. We want something very fast. And the reason of that, because every time you stop the treatment, patients can progress very fast and can cause some renal failure. And we might not be able to get these CAR T-cells back to these patients. So we want something on the shelf, hopefully that will be available. And we have that. The BiTE actually have been proving itself, which is bispecific. This is actually one of the things I want to say. It's a bispecific T-cell engagers. And what is this? This is really actually a very great treatment for multiple myeloma. And what they use is an antibody that actually holds the CD30 T-cells and the myeloma cells, which is BCMA, and try to bring it very close to each other for the T-cells to go ahead and attack the myeloma cells, same as the CAR T-cell does. So you don't have to kind of like take the T-cells out and engineer it. You just go ahead and give a drug for these patients. And these results, the initial results are really impressive with the durable response rate and all this stuff. So this could be a really great option for our myeloma patients. Now, I kind of like want to talk a little bit about other clinical trials. And unfortunately, I think I gave the wrong slides. But anyhow, I want to say that these clinical trials actually are available for myeloma. We have trials for smoldering myeloma, trials for maintenance and relapse and newly diagnosed myeloma. Common question I receive from a lot of patients in regard to these clinical trials that we have, and also we still have a lot of CAR T clinical trials and BiTE trials. The common question I receive from patients is that they are scared of these trials. They think they're a guinea pig. I want to remind a lot of patients that 20 years ago, the patient survival was very short due to the fact, that we didn't have great options. Now, because we have a lot of options of therapy, we see survival up to 15 years. We're hoping that we're going to achieve cure. CAR T-cell didn't get approved without the work, the hard work of our patients who participate, and the institutes who built it, and the pharma company who actually contributed with that. It got approved because we worked very hard, and we saw the great results, and we are hopefully going to see a real hope in the future of multiple myeloma for treatment for these patients. We do have, we do have a great clinical trials for CAR T-cell, and our program is open right now also for commercial CAR T-cells for myeloma patients who are triple and penta-refractory. By this, I'm going to end my last slide, because the last slide, I think it's not relevant to this one.
Okay.
Thank you very much.
What a great talk. Great presentation and pacing for all of us. For those of you that might have missed a slide or two here on this presentation, which is another very important presentation, I'm going to remind you again that it's going to be up on our website. If you have additional questions after you review that, you can call our toll-free number 800-452-2873. To remember that, it's 800-452-CURE. And you leave a message there, and one of our info line people will get back to you in a reasonable amount of time. So you have many, many options here, including myeloma.org. So with all that being said, let's look at some questions. Dr. Abdallah, do you see some of these questions on your chat box there? Okay, he might have fallen off there. Sid, can you answer some of these questions? I'm not sure where. Oh, there's Abdullah.
Oh,
Dr.
Yeah, I can hear you. Can you hear me?
Yes, I can hear you now.
So some of these questions were answered by Dr. Ganguly, so I want to see which questions are related to the relapsed myeloma.
Dexamethasone with CAR T on the first line of therapy.
New diagnosis, I think you say.
Yeah.
Could you theorize what kind of response a new diagnosis bunch would? Well, it's a great question. So I think if I may actually say that this is actually a question about using and utilizing CAR T-cell in newly diagnosed myeloma as a first line of therapy, and also a question about is there any clinical trials in this field? Yeah. I think there have been a lot of question mark about using CAR T-cell in newly diagnosed myeloma. And when you see something is really working very great in relapsed myeloma, and especially in those who are heavily treated, and you want to try to move it really, really upfront to see if it actually can last longer. There is some trials that they're trying to put CAR T-cell and to utilize it. It's very difficult to substitute stem cell transplant, and I'll tell you the reason why. The last study that we saw from the IMF, it was a very impressive trial that they did RVD transplant and followed by 1 year of maintenance therapy Revlimid. The progression-free survival for those patients who got transplant was close to, in 8 years, was close to 40%. Meaning like CAR T-cell really have to prove itself to compete with stem cell transplant. I don't see that's going to happen anytime soon. I think if they want to prove themselves, they have to go and have a head-to-head to convert themselves to transplant. I wish it can actually substitute transplant, but it's not a guarantee because transplant have been so far unbeatable. Nothing had beat transplant any time, any head-to-head studies, period. So if CAR T-cell wants to go to that direction, they have to have a head-to-head. But in my opinion, I think the best scenario is that which they're doing for those patients who are not eligible for transplant to kind of utilize CAR T-cell there. I think that makes a lot of sense to kind of do that. Are there clinical trials? Yeah, there are. I think KU also is opening a clinical trial for upfront CAR T-cell, but they're for these patients. We're still trying to open that trial. So we actually are seeing that is going to happen. Definitely CAR T-cell is moving to earlier relapse. We are seeing that. And they're trying to compare it head-to-head with other triplet therapy, which is also important because we want to see how effective it is. To answer that question is that newly diagnosed myeloma, it is going to be challenging. It's not an easy thing just to go ahead and replace it because it looks great. They have to prove themselves because stem cell transplant has been there for a long period of time. And so far, all the trials have shown that they're all inferior to stem cell transplant in keeping remission.
Great answer there. That's a lot of information.
Another question, I like this question about multiple myeloma in the form of plasmacytoma, and we have to identify what's plasmacytoma because sometimes it is not an easy definition. And like you see it in the bone, is that really aggressive? Versus if it's in the liver or other soft tissues, it's aggressive. I treat them as a high-risk myeloma. And to be honest with you, is it different? We have a lot of question mark about that. What treatment the patient had in the past, for example. So, for example, if the patient relapsed with an extramedullary disease on Revlimid, I will try to use Darapomdex on these patients. If they relapse on proteasome inhibitor, of course, I will try to utilize these drugs and newer agents. One of the things I experience is that these plasmacytoma are still sensitive to alkylating agents. As a matter of fact, to prove that how effective it is, the studies from the relapsed refractory myeloma from the Horizon that use Melfiqin, they look at the alkylating agent, the Melfiqin was effective in the extramedullary disease as a single agent. So that's something proving that, in my opinion, if you want to, if the proteasome inhibitors, the monoclonal CD38, and the newer immunomodulatory drugs doesn't work, using alkylating agents like Cytoxan or Melfiqin will make a lot of sense in these patients. So I'll say, if I want to be, definitely I'll need to be aggressive with these patients, but I'll try to kind of utilize a triplet therapy for these patients. Stem cell and T cells after transplant. Okay, I think one person, what is the possibility of using both stem cells and T cells after a transplant? Like after relapsed myeloma?
I can take that if you want me to, Dr.
Yeah, please.
Abdallah. So the question is very pertinent, and we're trying to answer that to the CTN, which is the Clinical Trial Network for the BMT groups. So there's a CTN 1901 and 1902. Two trials are coming pretty soon, where we're thinking of using CAR T or T-cell therapy after the transplant, and the goal is to mop up the minimal residual diseases. So the question is very pertinent. Can we use the stem cell transplantation to put a deeper remission, and then whatever is left behind, get it out by a CAR T therapy? That's the question that they're going to answer. So it is coming in future. It's a good question, and yes, it is in the horizon.
So I have also two questions here. Is that is there any studies done that look at follow-up treatment after CAR T-cell? Yes, we're starting doing these studies. As a matter of fact, now we're focusing on trials to show that patients who progress after BCMA CAR T-cells, and also there are some studies to actually try to re-challenge those patients who actually, let's say, stayed in remission for 1 or 2 years in CAR T-cell, to re-challenge them with another dose of CAR T-cell. So they want to see if actually more than one CAR T-cell can be worked on. And I think that is kind of like a reasonable, that we're going to hopefully we'll have answer. Do I believe CAR T-cell will lead to a cure? It's too early to say that. And I would really actually be very careful about the word cure right now. Very careful. Because every time I mention CAR T-cell, people associate it with cure. As Dr. Ganguly mentioned, like we have great results from transplant, but even patients who go to MRD negative, some of them still relapse. It is a great start. Let's start it from this. Let's put common sense here. When I show you the studies that relapse refractory myeloma, you guys saw that the survival after triple refractory was about 9 months, and penta refractory was 5 months. That's a survival. And you're talking about the response rate range in all the drugs that were approved by the FDA between 20 to 30%. The CAR T-cell kind of exceed that, 75%. That's a good start. 9 months in general, and those patients got complete remission 19 months. That is really impressive. And that's a great start, meaning like we still have a lot of room for improvement. And I think that's great. But imagine like all of this, we're changing the landscape of treatment of myeloma by utilizing the CAR T-cell. So I think it's too early to say the word cure. I would actually not, use it very often, that until we have more studies for these patients. Is it going to be used up front and change also? We're going to need a longer follow-up in order for us to, make that decision.
Okay, one more question, so we can keep on time.
So there's another question. I mean, there's a lot of great questions. I'm so sad I can't answer all of them. But can drugs used in some trials keep the patient from using the drug for future treatment? I think that's a challenging question for me to say that. Let's say I'll give you an example. If you are on a very simple one. Let's say you got belantamab and or you got daratumumab in the past days as a single agent, and in the clinical trials, and you progress on that. Would I use it as a combination therapy? I have used that all the time, and it worked very good. So you can use it, but in other clinical trials, I think it will be a no answer. Most of the trials will prevent you from entering the clinical trial if you have utilized one of their drugs in the past. But in real world, I think you can reutilize these drugs in a different way. For CAR T-cell patients, some patients tell me, I got CAR T-cell and I progressed on that. We have to look at what target was it. Was it CD19 or was it the BCMA? And we also have to look at the dosage, because the approval dosage was 300, 450. So if you got, let's say, 50,000 or 150, I think, in my opinion, that you should be actually eligible for getting a CAR T-cell in real world, So that will be my opinion for this reason.
Okay, what a great session there. Thank you, Dr. Abdallah. That was a lot of information. So remember, you can get this on our website at myeloma.org. You'll hear more about that as time goes on.